good friend of mine. Is he here? Yeah.
Yes, Dr.
Ajinkya
Apurva. Hi.
is going to talk about a squint case not being the end of the world when you get it in practical exams. I think squint is something everybody is afraid of. So Ajinkya is residency. He finished from Prabha Eye Clinic. He did his long-term fellowship in peds, ophthalm and strabismus from LV Prasad, and he's back in his alma mater as a consultant in pediatric ophthalmology. Go ahead, Ajinkya.
Thank you so much, Dr. Apurva. Thank you, AIOS and UC, for this wonderful opportunity. So I'll directly go to the topic. Bob Dylan said, doesn't expecting the unexpected make the unexpected expected? So quite a confusing quote, but it is very relevant. So we usually hear this, यार मुझे exam में squint case तो नहीं आना चाहिए. But no, mind you, the first and foremost step, expect the squint case in your practicals. I tell by my example, my experience. We were 4 people who were appearing for practical exams together, and 2 of us got either short or long case in squint. So yes, there is fairly 50% of the chance that you will get a squint case in your practical exams. So yes. So now you expect the squint case. How to prepare? So Benjamin Franklin said, by failing to prepare, you are preparing to fail. So now you know that you can get the squint case in exam. Now you have to prepare for it. Where does the preparation start? So the preparation starts right in the clinic, right during your clinical posting in the department of squint. The preparation for this squint case in exam start. Now I understand not all the institutes and hospitals have a dedicated squint department, but you must have an ophthalmologist who is dealing with such pediatric and squint cases. So whenever you are posted with them, or make sure that you get some time, dedicated time, like during your residency, to be around squint cases, so that you know the basics of squint, you know the basics of assessment of the squint case, so that once you start doing it, once you have seen it, then you know how to prepare for it. So long as I know what's expected of me, I can manage. So now if you have a case in exam, what are the points? What are the things you must know? Now, first and foremost, throughout the residency, don't neglect squint. You should know the squint. Everyone reads, everyone sees cornea, everyone sees retina, so everyone knows it. So unless you make an attempt to see a squint case and understand it, you will not get it. So know all the terms in squint thoroughly. You should know exo, iso, hypo, hyper, propia, phoria, dissociated deviation. Be thorough with it. You should know how to assess for abnormal head posture. You should just not miss it. That is the first thing you observe in your patient when the patient is sitting right next to you in the examination chair. The most important test in squint assessment is extraocular motility assessment. It does not require any fancy instruments or anything. It just requires one near target, and you can assess the motility, and it can lead to the diagnosis of most of the cases. Then you should know how to look for Hirschberg corneal reflex and how to interpret it. Then again, the very important test is cover and cover and alternate cover test. How many times you read it in book, you know it, you understand it. But unless you do it on a patient, unless you get an occluder of yourself, put it over the eye, look for the motility of the eye under the cover, the other eye. So make a habit, do it yourself. Unless you do it, unless you see it, unless you keep doing it, it will not come in exam. Be habitual of doing cover and cover test. And last is prism alternate cover test. Not all people would have access to prisms, but at least know how to use prisms. What are different types of prisms? What are base in prisms? What are base out prisms? How to hold the prism? How to stack the prism? How not to stack the prisms? At least know the basics, so that even if in the exam you might not have the prism box, but at least if the examiner asks you how would you put a prism in this case, to assess, to measure the deviation, you should know. There should be no confusion in the exam. You should know it beforehand. So these are some few must know things. Now again, like any other topic, there are few cold cases, few hot cases. We never expect any hot case in exams. Hot case means any acute case or any child who is very small and is will be uncooperative for examinations. So we can, like when we are thinking about the practical exams now, we can forget about these cases and focus on cold cases. What are the cold cases? So in comitant squint, accommodative esotropia, intermittent exotropia, sensory or constant exotropia. These are the comitant squint cases which you can expect. Other than that, in concomitant squint, you can expect nerve palsies. Ischemic nerve palsies are seen very often in all the OPDs daily. In each hospital, in each OPD, there will be at least one case. So on the day of exam, they would definitely have one case presenting to their OPD, if not prior. So you can definitely expect ischemic isolated cranial nerve palsy, and there also can be a case of Duane retraction syndrome. So just in brief, very brief about all these cold cases, what are the must know or good to know things when you need to pass the exam? So when there is a child, 2 to 5 or 8 years of age who is wearing the, hyperopic glasses, you don't know what is the case, just take out the glasses. It is likely to be a case of accommodative esotropia. So you should know the types of esotropia. You should know how to what is refractive accommodative, what is partially accommodative esotropia. You should know what is high AC by ratio. Then always remember to measure the squint in these cases with and without glasses. And then in brief, you should know about the management. Intermittent exotropia, you should know the types and classifications, different classifications. For that, you need to measure the deviation for distance and near both. You should know how to assess the control. What are the different types to assess the control? What is home control? What is clinic control? So you know already, you have read these things for theory, but while examining the patient, ask these things to the patient. Do these things yourself. Check for the control. Once you do it, you know it, and then you can keep doing it. And in brief, you can know the management options. Then third cranial nerve palsy, the eye is down and out. There is a ptosis. The case is clear. There is third nerve palsy. Then you should, for all cranial nerve palsies, like for all cranial nerve related cases, you should know the course of these cranial nerves, 3, 4, 6. The course should be on tip of your tongue. Then you should try, and depending on the location and the lesion or the symptoms and signs, you should try at least to localize the possible lesion, the location of the possible lesion. Then you should see and not miss if it is pupil involving or pupil sparing. Why it is important, that you should know. If it is painful or painless, it is complete or partial. These are all must know things. Then know what all are the indications for any cranial nerve palsies for that matter. What are the indications to neuroimage? What are the different fascicular syndromes one can encounter? And again, the management options in brief. And always remember, for any cranial nerve palsy, always check for all the cranial nerves. It does not take more than 5 minutes. If it is a habit to you, it will be just done in 5 minutes. But always check for all the cranial nerves, or at least mention. Then fourth, cranial nerve palsy. The patient complains of vertical diplopia, is coming with AHP. So this concomitant vertical diplopia will probably be your exam case. Even if you have this case or not, be sure that at least 50% of you would be asked about past 3-step test, either in a theory or practicals. Somewhere you will be answerable to what is this past 3-step test. Then assess the HP, know how to differentiate between bilateral versus unilateral, course, localization, and management options. 6, nerve palsy, again, you should know the course, you should know the localization, know what is pseudolocalizing sign, look for other neurological signs, ask for other neurological symptoms. Again, there are different fascicular syndromes associated with 6, nerve palsy, so ask for related signs. And again, you should know the management options in brief. Whenever there is a DRS case, first thing, you should identify that it is a DRS case. The patient with AHP, with globe retraction, with overshoot and the exotropia or esotropia. So first and foremost is identify, diagnose, type of DRS. Is it exotropic, esotropic, type 1, type 2, type 3? Then what is the mechanism of overshoot? What is the mechanism of globe retraction? These are the basic things one should know. And then if you know the management, that is like a brownie point, and you will definitely score great. Now, few points about OSCE. In an OSCE pattern, you can definitely expect diplopia chart, H chart, Worth4 dot test, Maddox rod, double Maddox rod, and synaptophore. So these are the things, tuck, tuck, tuck. It should come in your to-do or checklist before your OSCE exam. Then you should know different kinds of chart. They can show you the chart, and just you should know what is this type of chart, what is the principle behind using this chart. So these are different pediatric vision assessment charts. And in spotters, again, you can have a DRS case, a Brown syndrome case, MED case, or a case of leukocoria, and they would probably ask you for the differential diagnosis. These are the few I could think of, but again, there are always many things, but at least these things are like very often seen, and so you are probably most likely to get this. So take-home tips are: be familiar and used to examining a case of a squint, know the basics, know the theory, don't forget the theory, go methodical. The most important thing which examiner looks for you in an exam is how you approach the case. They don't expect you to manage that case or diagnose that case correctly, but what is your approach? Did you ask the history properly? Did you look for the HP? Did you check the extraocular motility? So have a set pro forma. And if you are lucky, so imagine that you are lucky if you get a squint case, because examiner think that it is hard for you, but now you are prepared, and so you will nail it. And so there is a low threshold for obtaining passing marks when you get a squint case. And make sure that you get few brownie points by knowing in detail about each of these things. Thank you so much. I hope डर के आगे जीत है.